Jamo Orthopaedics are proud to have partnered with Additive Orthopaedics to bring to the UK a range of 3D printed custom implants. The patient-specific devices enable surgeons to tackle the most complex foot and ankle reconstructions, including sarcoma, avascular necrosis, revision ankle replacements, and any other complex revision surgery. Additive Orthopaedics are the first company to integrate locking screw technology within their implants, offering far greater stability. For any further information, please visit our website at www.jamo-ortho.com.
Good evening and welcome to tonight's lecture. It is the 19th in our series of the Lectures of Distinction presented by the British Orthopaedic Foot and Ankle Society. Tonight we thank the support of Jamo Orthopaedics. The lecture follows shortly, but just as a reminder, the feedback and certificate access codes for your CPD will be put in the chat box of your Zoom screen later, so do keep an eye out for it if you haven't got the feedback code already. As usual, please submit questions as you go along via the Q&A icon in the bottom of your Zoom screen, and we will endeavour to get through as many as we can. So without further ado, I'd like to introduce tonight's speaker, Mr. Maneesh Bhatia. He is a consultant in Leicester specialising in foot and ankle surgery, having done his fellowships in Cambridge and a travelling fellowship to America linked to the European Foot and Ankle Society. He is currently the Education Secretary for the British and Indian Orthopaedic Society and hosted their international meeting in 2019. He has served BOFAS on our scientific committee and currently sits on the European Foot and Ankle Society Scientific Committee. So it gives me great pleasure to introduce tonight's speaker on the subject of tumours and pseudotumours of the foot and ankle, Mr. Maneesh Bhatia. Thank you, Maneesh.
Thank you, Tim, for a very kind introduction. I'll share my screen to start the talk. Can you see it and can you hear me?
Yes.
Thank you. So thanks, BOFAS, for giving me this opportunity to talk about common tumors of the foot and ankle. Now, my disclosures. So I don't have any conflict of interest. I'm not a tumor surgeon. However, I'm a foot and ankle surgeon, and I prepared this talk based on people taking the exam, so for trainees. I've also used some images in the talk from online sources and various publications, and I have acknowledged them where possible. So, tumors of the foot and ankle are divided into two groups: pseudotumors, which are tumor-like, and the examples are Morton's neuroma, ganglion cyst or synovial cyst, and mucus cyst. And then the tumors of the foot and ankle are either benign or malignant, and they could arise from either bone or soft tissue. So looking at how prevalent are foot and ankle tumors. So this is from a tertiary tumor center in Germany. And out of 7,487 musculoskeletal tumors, the incidence of foot and ankle tumors was 5.5%. And 2/3 of these involved bone, whereas 1/3 involved soft tissue, and majority of these tumors were benign. So based on their work, they didn't include the pseudotumors, so they just focused on the real tumors, benign and malignant. And the commonest soft tissue benign tumor was pigmented villonodular synovitis, and then followed by plantar fibromatosis. The commonest benign bone tumor was simple bone cyst, followed by achondroma. And the commonest malignant soft tissue tumor was Synovitis, and the one which was malignant arising from bone primary tumor was Chondrosarcoma. Now, this is a very recent study. It's not published. It's in Press Foot and Ankle Surgery. This is a study from Singapore, and they have reviewed all the soft tissue tumors, including the pseudotumors. And I found it quite interesting and educational, good for exam to quote as well, that the factors predicting malignancy are male sex, age more than 66 years, and size of the mass if it is more than 4 centimeters. And the commonest tumors in their experience, so pseudotumor, the commonest pseudotumor was ganglion. The commonest benign soft tissue tumor was plantar fibroma, and the commonest malignant soft tissue tumor was pleomorphic undifferentiated sarcoma. Now let's talk where the tumors happen, and based on the location, can we talk more about these. So one good thing to quote for exam to get brownie points would be, if you are ever presented with any lump or bump in the exam, then just refer to zones of the foot by Kirby. And these are the 5 zones. So first one is ankle, the second is heel, the third is the dorsum of the midfoot, the fourth is the plantar aspect, and the fifth is the toe region. So the commonest tumors which arise from the dorsum are the synovial cyst or ganglion and lipomas. And the commonest to arise from the plantar aspect are the fibroma, inclusion cyst, or foreign body reaction. Let's talk about some anatomy, because that's important. And it's important here because, as we know, the foot and ankle is divided into various compartments. So what is the relevant? The relevance is that if there is a tumor or infection, it can localize to a certain compartment. However, there are tendons passing through these facial planes, and therefore it can pass from one to another compartment, but the progress is halted for some time. So just a quick recap, foot is divided into 4 compartments, the extensor compartment, and then the plantar compartment initially. And the plantar is subdivided into the medial, the red one, central, the blue one, and the lateral. So medial houses the tendons for the muscle and tendon for the big toe, and the lateral houses that for the 5th toe. And in between, we have flexor digitorum longus, flexor digitorum brevis, quadratus plantae, and adductor hallucis, and lumbricals as well. Ankle, on the other hand, we have 4 compartments. So the one in red here is the medial compartment, the tibial nerve here. So this is lined by flexor retinaculum. Then we have our posterior compartment, the one in blue. The one in green is the lateral compartment, which has the peroneae, and it's lined by superior peroneal retinaculum. And then we have the extensor compartment on the top, which has all the extensor tendons and neurovascular bundle. So now, in terms of assessing a patient with a tumor, so history taking is always ever so important. The important salient features here with history are that obviously one of the red flag signs is night pain. So night pain should ring alarm bells. Now, some patients with tumors, they present with non-mechanical pain. So what it means is that they complain of pain, which what we can't really explain. And this was the predominant symptom in the series by Young from Royal Orthopaedic Hospital in Birmingham, that if patient presents with non-mechanical pain, it should be taken seriously. And then there are certain malignancies which are not associated with pain. So anything which is slow growing, been there for quite a long time, does not produce pain. And the example of that is Synovitis. The other red flag sign is, or history, is a sudden enlargement in size or shape. Just to bear in mind that foot and ankle is slightly different. And if there are deep-seated tumors, then sometimes they are not even visible. And sometimes they might just appear suddenly. So it's important, but not always the case. And lastly, never forget about constitutional symptoms, and especially history of smoking, because we can get meds and we need to be careful about all these pointers, which can be important in the history otherwise. The next thing which I would like to focus upon is X-rays. And we are talking about foot and ankle, but this applies to any tumor if you are presented in the exam and if you are shown an X-ray, and you should have a scheme. And my way of talking about any X-ray is to start with soft tissue. So in terms of tumor, we are talking whether the soft tissue is normal or you can see any mass or calcification in the soft tissue. Then we talk about the periosteum. Is the periosteum normal? Is there a reaction? If it is a reaction, then is it solid or interrupted? Because in benign tumors, where there is time for periosteum to form, there is solid reaction, whereas in certain malignant tumors, it could be interrupted. The next thing is whether there is cortical involvement. So is the cortex involved at all? Is it just scalloped? Is there any breach of cortex, or is there any destruction of cortex? So obviously, that is the grading based on the aggressive nature of a tumor. Then lytic lesion. Lytic lesions, so first of all, can you see any lytic lesion? Then is it one or multiple? And then the term used is geographic versus permeative. So if it is benign, it is well defined, geographic, and if it is poorly defined, multiple lesions, then it becomes moth-eaten or permeative. And then zone of transition. So what do you mean by zone of transition? How the tumor is actually, how can you differentiate between the normal tissue and the tumor tissue? So whether it is narrow, which will be the case in benign, and if it is wide, which is haphazard and you can't really make out, it's spread in the normal tissues, then that would be aggressive nature of that particular tumor. So just this slide I borrowed here, so just shows very nicely. So we are from left to right, we are moving from benign to most aggressive permeative. So we see here geographic, well defined, and there could be a nice sclerotic rim, which is very, very benign. And sometimes geographic might not be that well defined. And then we come next phase as multiple lesions, and this is moth-eaten appearance. And then when it becomes further aggressive, this is your permeative destruction of the bone. And this is an example to show calcaneum is one of the most commonly involved bone in the hindfoot. So this slide on the left, we can see there is cortical involvement. There is a wide zone, which means you can't really differentiate. And there are multiple lytic lesions, which is like permeative. And this is a case of Ewing sarcoma. This one here, you see a cyst here, nicely lining. So this is a geographic area. There is a rim around it. Can't see any cortical destruction, and there is some sclerosis. So this is a benign, and this is a simple bone cyst. This one here is the calcaneum is completely destroyed. There is a large lytic lesion. It seems like there is something happening for a long time. So this is a case of chronic osteomyelitis, and then there is squamous cell carcinoma on the background of the chronic osteomyelitis. This one here again shows a wide zone, with calcification, and this is classical appearance of a low-grade chondrosarcoma. The next investigation, so after X-ray, which is really important for bone tumors, MRI scan is mandatory and is the gold standard. And this example here, the horrible looking lesion here, X-ray shows there's something going on. And when you do the MRI scan, it shows this bright signal in the FET suppressed image. So you can see the replacement of the normal marrow by the abnormal marrow, and then extension in the soft tissue, which is bounded. So this is actually malignant lesion. It's a metastatic lesion in this particular case. So now we are going to talk about some benign tumors of foot and ankle. So primary benign tumors. So first one, this one is quite common. This is an incidental. So you have asked for an X-ray and you see this picture, and that's a classical finding of intraosseous lipoma. So what do you see? So the location, it's next to the crucial angle of Gissan, geographic, sclerotic margin, and then sometimes there is calcification in between, which is due to the necrosis of the fat here. Okay, so it's benign, nothing to worry about this one. Coming to exostosis. Now, exostosis or osteochondroma in the foot are not very common. And if you look, I tried to do literature search and there are isolated case reports. But what is common is the subungual exostosis, and also known as Tourette's exostosis. So benign lesion, there is history of trauma. You differentiate it from osteochondroma, where location is classical and the appearance is classical, and it doesn't communicate with the medullary canal like the classical osteochondroma, either on the X-ray or the CT. And most of these, if they're symptomatic, they can be excised. Next common primary bone tumor is enchondroma. So it's a cartilaginous lesion in the medullary canal. And again, it can be an incidental finding in phalanges, mostly in the foot. Important is that this is a benign tumor, and you see scalloping because it's an expansile lesion. But exam point of view, remember Ollier disease or Maffucci syndrome, multiple enchondromatosis, and Maffucci syndrome is when you see hemangioma, when there are multiple hemangiomas as well. And they have a high risk of malignancy in the order of about 40%, which increases with age and also with the involvement of pelvis. So this is something which is commonly asked in exam. And when you are describing them, so sinister features, you're looking for any cortical breach, soft tissue extension, etc. Then simple bone cysts. So they can be of two types, unicameral bone cyst or aneurysmal bone cyst. So MCQ question, fallen fragment sign, what is it? It's a pathological fracture you see, and there is the fragment lying in the cavity, which is the fallen fragment sign, the fracture fragment. ABC is usually more expansile lesion, and in foot it is seen in the metatarsals. MRI scan, the classical picture is fluid levels as shown here, and that's due to the different age of the fluid and blood products. Now we'll come to some benign soft tissue tumors of the foot and ankle. So the commonest is plantar fibroma or plantar fibromatosis. So plantar fibromatosis is referred as Lederho's disease, and it's a hyper-proliferative and locally aggressive disease. The commonly associated risk factors are diabetes, low body weight, epilepsy, excess of alcohol, smoking, and in about 20% cases, there is familial history. These could be bilateral in up to 50% cases. And the common association of plantar fibromatosis is with Dupuytren's in up to 21% cases, Garrett's nodules, which you see at the PIP joint, and then penile fibromatosis, which is seen in up to 1 to 3% cases. So you can be presented with an exam because obviously these are benign cases and good short case. So important questions which could be asked is you need to know about the stages. So they have 3 stages. The first stage is that of activity cellular proliferation. And in these particular cases, you can't really see the nodules. So patient presents only with pain. The second stage is that of nodule proliferation, and whereby you see enlargement of nodule. And then the third stage is that of the collagen maturation and scar formation and tissue contraction. So these are the stages to be remembered. Imaging, do you need to always do it? Well, if it is a straightforward plantar fibroma, then you don't necessarily need to image. But if you have doubt, if patient presence of pain, if there is sudden change in size, and if you're planning surgery, which normally doesn't happen, but if that is the case, then it's a good idea to get a scan, and I would suggest getting an MRI scan to see the extent of involvement to the deeper muscle layer as well as to the skin. This is a very good paper. So Judy Baumhar has published this current concepts review in Foot and Ankle International. And this is based on the evidence. So treatment options for plantar fibromatosis, what is not here on the list or the table is non-invasive. So first of all, you try the use of insoles or custom-made orthotics or carbon foot plate or rocker soles. Then the next treatment option is steroid injection. The literature suggests that one steroid injection doesn't work and you have to go for multiple injections. And there is good evidence in Dupuytren's, whereas not a lot is written regarding plantar fibromatosis and steroid injection, its success rate. The side effects obviously are the depigmentation of the skin and fat atrophy. Radiation therapy is a well-known entity, published, but not much known about the recurrence rate. And there are side effects, so erythema, blistering, skin changes, etc. Then we're talking about surgery, and the surgery could be in the form of either just a local excision of the nodule or the fibroma, or a wide excision where you have a normal layer of cells between normal skin as well as you've excised it completely. And then there is complete plantar fasciectomy where you've done a radical clearance. There are a couple of systematic reviews and they all favor that if you have to do surgery, then wide excision is the better, which has got the least recurrence rate, up to 20%. Of course, wound healing problems, whatever you do is always a risk, but it avoids issues such as collapse of arch, which is commonly associated with plantar fasciectomy. The next common benign tumor is pigmented villonodular synovitis, or PVNS. So this arises from the synovium, and 7% involvement in ankle and 2% in the foot. That's what we see. PVNS is of 3 types. One is the localized, which you see just as a nodule in the joint. The second one is the diffuse, called diffuse giant cell tumor, which involves the synovial lining and then infiltrates bone. And the one which involves the tendon sheath is the giant cell tumor of the tendon sheath, which is the extra-articular equivalent of the localized PVNS. This is a good paper for exam about diffuse giant cell tumor. So presentation can be variable, so they can be asymptomatic, and the extreme could be marked pain, stiffness, flocking, everything. These patients would need an MRI scan as well as a biopsy before surgery. This is the typical appearance here. Large, more than 5 centimeter mass, various shades from tan to brown due to hemosiderin deposition, giant cells, macrophages in the histology, and treatment is total synovectomy. However, it has been shown that asymptomatic patients can be managed non-operatively by surveillance. So next, we are now coming to common pseudotumors of foot and ankle. Morton's neuroma, one of the commonest and appears in exam in the Viva pathology setting. So neuroma, as its name suggests, it's not a true neuroma, but it is fibrosis due to fibrosis, thickening of the interdigital nerve, mostly due to pressure compression. You might be asked to draw histology. So histology is characterized by a neural edema, perineural fibrosis, as shown here, and in later stages, there is axonal injury. How does it present? Well, it isolated the pressure on forefoot, anything which causes isolated pressure. So hallux valgus deformity, tight-fitting shoes, high heels, runners, injury, etc. Symptoms: patients can, most common presentation is pain. So either burning pain, which is localized on the plantar aspect. Sometimes it can radiate to the toes. Patient can complain of altered sensation in about 50% cases. Pebble in the shoe is another common way of patients describing it in 50% cases. It can also come as a short case. So an examination, what are the important features? So first of all, inspection, what do you check? So you look at any hallux valgus deformity. You look at the plantar aspect of the foot to rule out any plantar callosities. And then you comment on whether there is any splaying of the toes, which could be due to intermetatarsal bursa enlargement. The common tests are thumb index finger squeeze test, which I commonly use. So this one here, and it's quite a sensitive test in my experience. Mulder's click is used, but we have shown that Mulder's click is positive only when the neuroma is large, so more than 1 centimeter. And then the other test which is used is plantar percussion, causing pain and sometimes tingling. Very important to check out if there is any tenderness in the metatarsophalangeal joint, in the adjacent joints, because that's the commonest differential diagnosis, any pathology related to lesser MTP joints. Check for sensations. If sensations are abnormal, that gives a very good clue. And then we were talking about pressure on the forefoot. So Silverskiol test, which you rule out gastrocnemius tightness. That's an important test to suggest an exam if you think that there might be increased pressure on the forefoot. Important is the clinical diagnosis, and then weight-bearing radiographs are important because they can show the deformity of hallux valgus. They can show synovitis, increased joint space in the lesser MTP joint, sometimes Freiberg's disease in a young patient. When do I use scan? So MRI or ultrasound, both are good, depends on ultrasound if you got a good MSK radiologist. So I use it if I have any doubt in the diagnosis, if you are planning ultrasound guided steroid injections, and certainly I'll do a scan if I am planning to operate on these patients. Treatment. So non-surgical treatments, how can you treat? And look at the literature. There are all sorts of treatment described for Morton's neuroma, starting from insoles, shockwave therapy, Botox, laser, capsaicin, hyaluronic acid, you name it. And none of these have any evidence in literature that these work. Steroid injections, they have a good evidence. Steroid injection, we've recently published in Foot and Ankle International that the effect of a steroid injection, single injection, can last for up to 5 years in 1/3, 33% cases. Alcohol injections, a lot was talked about these, and promising results when initial study came from Stanmore. Unfortunately, further studies shown that the effect was not as good in the medium term, and more worryingly, there were significant side effects, and some patients had a lot of pain in the foot following alcohol injections. radiofrequency ablation and cryotherapy, there is some suggestion, some evidence that they work, but we don't have long-term studies. The best outcome time-wise is maximum up to 9 months. So we need more evidence, but yes, it could be something which can be considered in future. And then if non-surgical treatment options fail, then surgical treatment. So you could be asked in exam, how do you operate? So approach, most foot and ankle surgeons use dorsal approach. Important thing to know is that this is a deep structure, so you need to divide the intermetatarsal ligament. It is really important to dissect the neuroma both distally and proximally, and then to send it to the lab to confirm the diagnosis. For outcome, you might be asked to quote a paper, and this Bucknell's paper in 2016 in BJJ is a good paper to quote, showing that 80% are either good or excellent, good or excellent, whereas 10% can be poor. So keep that in mind. And results of revision surgery are not very good. So try to avoid them if possible. The next pseudotumor is ganglion or synovial cyst. So it's the commonest soft tissue lesion, up to 40% of cases in various series. The differentiation between the synovial cyst and ganglion, so it can be lined by true synovial cells in case of synovial cyst versus pseudosynovial cyst. And in synovial cyst, it always communicates with the joint, whereas in case of a ganglion, it doesn't always communicate with the joint. And people say that ganglion is an advanced or degenerate state of a synovial cyst. So that's the difference. The commonest location is tarsal tunnel in the ankle, and on the dorsal aspect of tarsometatarsal joint, one of my cases. So osteophyte and then ganglion. How do you treat them? Well, if you do nothing, then 50% will resolve. So that's a good approach. Aspiration, you can try. Maybe some people put steroid injection as well, but the problem is that almost all of these come back. So I don't do it. Surgical excision, in the past, it was said that they have a very high risk recurrence rate. But this prospective study from 2010 has shown that the recurrence is not very high, 6% recurrence complication rate in terms of, because most of these are located close to nerve, so either here or in the tarsal canal. So 10% risk of paresthesia. I was surprised when I was preparing this talk. I didn't know that ganglions can be excised arthroscopically, but here we go. There's a paper published in a very respected journal, but then slightly higher risk of recurrence, 12% and 4% risk of paresthesia. So now we come to malignant tumors of foot and ankle. So important things to know about malignant tumors. So first thing is that clinical symptoms are not very straightforward in foot tumors. There could be a history of trauma in 20% cases, and some malignant tumors can mimic infection. And therefore, misdiagnosis is quite common. And unfortunately, the diagnostic delay, which has been shown up to 1 year between the mean duration of onset of symptoms and referral or diagnosis, is 1 year. And this can affect the prognosis adversely, leading to recurrence or amputation. What is the prognosis? Well, it's pretty similar to all other tumors except tumors in other parts of the body except that of chondrosarcoma. So chondrosarcoma has a favorable prognosis in foot and ankle with 5-year survival rate of 74%, whereas Ewing's has poor prognosis with 5-year survival of 58%. Next question, biopsy. When to do it? So it should be done, there's no doubt about it, but it should be only done after the imaging has been performed. Otherwise, the imaging, if you have to do after biopsy, will be compromised. Who should do it? It should be done at the regional sarcoma center. So all malignant tumors should be referred to the sarcoma center. And who should do it? So either the surgeon who is going to operate or the radiologist who is involved. Most well, almost all deep-seated tumors or tumors where you're not sure, you should have the biopsy beforehand. But the small tumors, superficial tumors, can have an excisional biopsy. And in foot and in hand, we talk in terms of 1.5 centimeter is the range of small, when we call it's a small tumor, so you can perform an excisional. So we talk about the commonest malignant soft tissue tumor, which is synovial sarcoma. So as high as 55% incidence. So first thing to say about synovial sarcoma is it doesn't arise from synovium. So it arises from the structures which are adjacent to the joint, but not from the actual synovium. It does affect a younger population. And this is one of the tumors which grows for a long time. So patient might present with a painless swelling, which has been there for many years. And therefore, because due to absence of pain, this is misdiagnosed and synovial cyst or plantar fibromatosis, and people might aspirate it, and that compromises the outcome. So this is a picture here showing MRI scans. So obviously with a large lesion like that, this MRI scan modality should always be used, and it will show an irregular mass extension in soft tissue and a very high signal, and these are the characteristic features. This tumor has metastatic potential, and these tumors can recur many years down the line. So next one to talk about is the malignant tumor affecting the bone. The primary tumor, the commonest, is chondrosarcoma, especially after the age of 40 years. And the commonest location is calcaneus. And this is the example here. So we talked about the malignant tumors. Here's a cortical breach. Not sure about soft tissue extension, but the destruction itself, we see a wide zone, and there are multiple lytic lesions, sort of permeative, not much calcification, so it's a higher grade of chondrosarcoma. Ewing sarcoma, important to mention because it's the commonest tumor involving foot and ankle, malignant tumor in children and adolescents, and it tends to occur in metatarsals, talus, and calcaneum. It's a very aggressive tumor, so remember permeated or moth-eaten pattern. And in diaphyseal bones, it can produce what we were talking earlier as the periosteal reaction, so onion peel appearance in diaphyseal bones. That is the classical. How about metastatic lesions? So this paper here from Birmingham showed that the incidence in their particular case was as high as 21%, and the most common primary sites were lung and breast. And it usually, unfortunately, presents quite late with generalized metastatic disease. And therefore, we can see the median time to death is 20 months. So if you see a metastatic lesion in foot and ankle, that's not good news. So we talk about the principles of treatment of the malignant tumors. So first thing to say, we said already that they should be dealt with at the specialist sarcoma center. And the treatment is based, we need biopsies, so histological diagnosis, and obviously the staging of the disease. Chemotherapy is particularly useful in osteosarcoma and Ewing sarcoma. Radiotherapy is particularly useful in Ewing sarcoma and also for the management of these soft tissue tumors. Chondrosarcoma does not respond to adjuvant treatment, and the main treatment for chondrosarcoma is surgical. Talking about surgery of malignant tumors, the principles, the MDT should have at least 2 surgeons and 1 specialist MSK radiologist so that they can plan a complete resection and to see if it is feasible to do a resection or not. The resection itself is in the form of wide resection. So what is wide resection? There should be a normal layer of cells between the surgical cut and the tumor margin. So you could be asked in exam about the resection margin. So remember, there could be intralesional resection, it could be marginal resection, it could be wide resection, or it could be radical resection where the entire compartment is excised. So take-home messages from this talk. If you have a patient where you're not sure about the diagnosis, patient keeps on complaining pain, investigate, think, and don't just discharge the patient because they have pain which you can't explain. Infection, whenever you think infection, think tumor. Whenever you think tumor, think infection. They should be considered together. Malignant tumors are not very common, but they should be kept in mind, because if you don't keep in mind, the diagnosis could be delayed and the outcome could be adverse. And imaging should be considered before you consider any local treatment or biopsy. These are the take-home messages from the talk. Thank you very much. Over to you, Tim.
Thank you, Maneesh. An excellent and very comprehensive talk indeed. I'm very grateful to you on behalf of everybody. There have been a few questions come through, if you don't mind. Just picking up on the last few slides there, most of us won't work in tumour centres. How much of a workup do you do before then referring on to the MDT and the tumour centres, etc.?
So I work in University Hospital, and luckily I have access. We have a soft tissue sarcoma, my colleague Rob Ashford. So what I do is, if I get a case, I pass on to him. We go through the case. In some cases, we do combined operating. So we are lucky. And sometimes if we do soft tissue sarcomas, we do in-house. But if it is bone, then we refer them to our regional center, which is Birmingham.
We don't see many of them, as you say. In which case, there's a few questions going back in through the talk regarding the more benign conditions. Again, your practice with Layder-Hose disease, with plantar fibromatosis, what's your kind of pyramid of management? You mentioned all different options there. What do you have available to you? So,
Tim, the one thing which I didn't summarize, that overall recurrence rate is very high after surgery. So altogether, the recurrence rate is at least 75%, if not 100%. Secondly, the complication rate is very high. So you see complication rate, it has been described in literature as to 50%, in the order of 50%, which is very, very high. And 20% cases do need plastic surgical input. So because of all those reasons, I am very, very, very reluctant to operate on these patients, last resort. So I have so far, in 11 years as a consultant, I have operated about 6 times maybe, when I'm really forced to operate. So my first line is orthotics, insoles, custom-made insoles. And second line is steroid injection. And if a patient presents with pain, steroid injections do work well in my experience. So I do try them. But as I said, that there will be some patients where you are forced to operate.
And with those steroid injections, are they intralesional? Are they into the fibroma, or are they around it?
They are intralesional.
Thank you. Okay, some other questions here, moving on to Morton's neuroma. Just one person's asking for a bit of a reiteration about the diagnosis of it. Is it purely clinical? Do you use imaging? And basically, what type of imaging would you use to try and clinch the diagnosis and start treatment?
So, Tim, I believe that Morton's neuroma should be a clinical diagnosis, and imaging should be used only if in doubt, because I have seen examples where people have just sent the patient to imaging, and it has been done by a sonographer, with all due respect, but the diagnosis comes comes as normal, and then patient knows they have Morton's neuroma because they had on their other foot. So I've seen those cases. So that's why I say, if you in doubt, then you use imaging. But obviously, there are cases you will see, and I'm not 100% sure, because intermetatarsal space is so close to MTP joint that they could be close. But most cases, we did this study we published where 98% cases where we thought was Morton's neuroma was confirmed on ultrasound scan. So clinical diagnosis is quite good for diagnosis.
On that matter, you mentioned that a common treatment you go to is steroid injections. Do you tend to do them yourself in clinic, or do you get them under ultrasound? What's your preferred technique?
So this is something which I had in my mind when I started as a consultant. And we set up a randomized controlled trial for this particular question, and we published this in 2016. It's published in BJJ. So ultrasound guided injections versus sham injections, where a blind injection ultrasound was not used, and the results were that there was no difference. So all the injections were performed by a musculoskeletal radiologist. So he used, in 25 cases, an ultrasound scan. In 25% cases, he switched the probe. So it was a blind injection. Results, no difference at 1 year. And we have prospectively followed these cases, and we've just published in Foot and Ankle International. So 4.8-year result, no difference again between the two cohorts, and the effect is lasting in 1/3, 33% of cases still have benefited from the injection.
And I think a question you're not going to be surprised by, but with the surgery for Morton's neuroma, if you've got ultrasound confirmed, second, third, and fourth, or multiple metatarsal interspaced neurometer, would you consider simultaneous surgery on all of them at the same time, or would you do it at separate occasions? How do you approach multiple neuromata?
That is an excellent question. And I'll tell you what, Tim, I don't know the answer. Well, we are actually, a medical student is helping me. We are doing a systematic review. So I'll tell you what we have found, and I'll tell you what my practice is. So first, we have found. So what we have found is if there are multiple neuromas involving both second and third intermetatarsal space, then the treatment in literature is single incision surgery. That is what we have found. What my practice is, I am based on anecdotal, I'm reluctant to operate on two neuromas at the same time. So whether I should change my practice based on the evidence, I don't know. But I have this concern that if you make two incisions, certainly there is risk of complications. Even with one incision, the patients can have more complications. So I'm reluctant to offer. So I tend to do this. I operate on the more symptomatic one and I inject the less symptomatic one. That's what I do. And I warn the patient that you'll come back for second stage, and it works.
That's exactly my practice. Take out the big one and then see how the little one goes and inject it and start again if necessary. But you do come across it, don't you? I mean, we're often discussing it at various meetings and bits and pieces, aren't we?
Absolutely. I mean, the thing is, Tim, that the previous literature suggested very low incidence of concomitant neuromas involving second and third spaces. But the more we do, we see, I mean, now almost 1/4, we have seen about 28% involvement of second and third. So it's very common.
Okay. There's a question here, moving on slightly, about another one. It's quite specifically asking, how do you deal with a posterior tibial nerve benign tumor? So
I have seen a couple of schwannomas. And how do I deal? So, well, as I said, the way I deal is I discuss it with my tumor surgeon. We do an MRI scan, and then we plan the excision. And we have done the combined operation. We have excised the schwannoma. In one particular case, it came back and we did it again. So yes, we excise it.
A question moving on to enchondromas. So an enchondroma of a phalanx often will present as a pathological fracture in which you'll see the enchondroma appear. Do you image that any further, discuss it with tumor units, or would you tend to recognize it by the X-ray findings as you put through so nicely, and it just immobilize and treat?
So if it is multiple enchondromatosis, then definitely I have a very high suspicion. If on X-ray it's a pathological fracture, it's an incidental finding and they come with pathological fracture and the features are benign, it's a solitary, I wouldn't bother imaging it further.
Brilliant. I think for the moment, that's some good questions. Thank you very much for 45, 50 minutes of speaking and education for everybody. I'm very grateful to you indeed on behalf of the British Foot and Ankle Society. Thank you.
Thank you very much.
Just to close then, next week's lecture is by Mr. James Stanley of York, who will be speaking on the Achilles tendinopathy talk. So please join us. It's next Thursday on the 17th of December at the usual time of 8 o'clock. Please look in the chat panel and you'll see the code for the feedback and your certificates that you can use after the lecture. And finally, just for me to thank both our speaker, Maneesh Bhatia, but also thank tonight's sponsor, JAMO Orthopaedics. And with that, I'm going to wish you all a very pleasant evening and say good night.
JAMO Orthopaedics are proud to have partnered with Additive Orthopaedics to bring to the UK a range of 3D printed custom implants. The patient-specific devices enable surgeons to tackle the most complex foot and ankle reconstructions, including sarcoma, avascular necrosis, revision ankle replacements, and any other complex revision surgery. Additive Orthopaedics are the first company to integrate locking screw technology within their implants, offering far greater stability. For any further information, please visit our website at www.jamo-ortho.com.